Welcome to PGOG postgraduate class in obstetrics and gynecology, and today's topic is labor dystocia, the controversies and conclusion. Literal meaning of dystocia is difficult labor. It is either a prolonged or abnormally slow progress of labor. Dystocia is the most common indication of primary caesarean section, and that is why it needs attention to reduce unnecessary caesarean sections. Now, whether to use the terminology as dilation or dilatation of cervix. This dictionary meaning of dilation is active process by which a structure is enlarged, which is usually used for cervix or pupils, and this is used for cervical change in labor by American guidelines. On the other hand, dilatation, this dictionary meaning is pathological stretching, which is mostly used for the bowel stretching, which occurs proximal to the obstruction. But this dilatation terminology is used by WHO as well as by UK guidelines and FOXY Indian guideline also to describe the change in the cervix, cervical change in labor. And that is why in today's class, we will be using this terminology, dilatation, cervical dilatation, to describe the change in the cervix. What are the causes of dystocia in a singleton pregnancy with a cephalic presentation? We can divide these causes in 6 P's, and I think it is easier to remember the causes under these 6 headings. Power, passenger, passage, we all know we are always using these 3 whenever we discuss labor. Power is related to uterine contractions. Contractions are inadequate, it will lead to dystocia. Passenger is the fetus, and if baby has malposition, malpresentation, macrosomia or anomalies, that will lead to dystocia. In the passage, abnormal type of pelvis, small pelvis, pelvic tumors, uterine anomaly, anything which obstructs the proper passage will lead to the dystocia. Patient is here either a maternal condition or the neonatal condition, such as nulliparity, elderly patient, obesity, hydramnios, chorioamnionitis in labor, short stature, and abnormal fetal heart rate patterns. All these are the important points whenever we evaluate a patient and see what are the causes of dystocia. Psyche of the patient also affects progress of labor. That is why this is the 5th P. And the provider, how the provider is assessing progress of labor, whether there are any errors because of the subjective assessment, and whether there is a need for second opinion. All these factors come under the 6th P. So we have 6 P's: power, passenger, passage, patient, psyche, and provider. Pictorial, sometimes we can remember better. That is why I have tried to divide these causes pictorially, as passenger is the baby, where there can be malpositions such as occipito-posterior, occipito-transverse, or synclitism. Malpresentations such as face, brow, or sincipute is also malpresentation, where there is a marked deflection and the sincipute is presenting over the internal os of the cervix. Then we call it as a sincipute malpresentation, or there can be macrosomia or fetal anomalies. In the passage, it can be a small gynecoid pelvis, or it can be anthropoid, android, or platypaloid or flat pelvis. Pelvic tumors can be there, or uterine fibroids also. Large fibroids can obstruct the passage. In the power, we have inadequate uterine contractions. Apart from 3 P's, we have patient, where the maternal and fetal condition, psyche, and provider. Factors also are to be reassessed whenever we try to find out the cause of dystocia in a given patient. In the uterine dysfunction, that is in power, we have 2 types. One is hypotonic uterine dysfunction and other is hypertonic. Hypotonic is where the baseline tone is normal. Contractions are synchronous but are insufficient to dilate the cervix. In the hypertonic, either there is an incoordination of the uterine contractions or there is an increased basal tone. So we should remember these two types of the uterine dysfunction: hypotonic uterine dysfunction and hypertonic uterine dysfunction. Both can lead to dystocia or prolonged or arrest of labor. Now, if we see dystocia, we can divide it depending on the stage of labor as first stage dystocia and second stage dystocia. First stage of the labor again is further divided into latent phase and active phase. Latent phase prolongation is also called as dystocia, whereas active phase dystocia can still further be subdivided into protraction disorders and arrest disorder. So this is the most important, the second stage. This is the most important slide. Students should remember how we divide dystocia, because accordingly we diagnose and treat dystocia. So either it can be first stage, in first stage it can be latent phase or active phase. In active phase itself, either it can be protraction, that is a slow progress of labor, or there can be arrest disorder where there is no further progress at all. Now, why do we divide the first stage of labor in latent phase and active phase? The reason is, in latent phase, the cervical dilatation is slow and unpredictable. So that the duration of the latent phase varies from patient to patient. And always important is, we have to need to consider false labor as a differential diagnosis of latent phase. So many times we get a patient, we admit the patient, retrospectively we diagnose the patient as a case of false labor and not as a latent phase of labor. We can even discharge and readmit the patient in latent phase whenever we consider the diagnosis as false labor. But there is a question mark about it, because so many times, sometimes it happens that patient might not reach next time in time, and it is better to keep the patient admitted if she is coming from a far off place, especially in countries like India. Then in developed countries, this option is also discussed in the textbooks, whether there is option we should consider home care for latent phase of labor. I think that is also not applicable for countries like India, where reaching to the hospital itself can be time consuming for the women. Now, first coming to the latent phase prolongation. Now, this terminology is usually not used for latent phase as dystocia. It is used as latent phase prolongation, whereas for active phase, the terminology is used as dystocia. So, in latent phase, that latent phase is prolonged is, the textbook definition is, if the duration of the latent phase is greater than 20 hours in nullipara and greater than 14 hours in multipara. These two figures students should remember. Now, latent phase always needs to be differentiated from false labor. It should not be an indication for cesarean section. Prolongation of latent phase should not be an indication for cesarean section is the latest guideline which is given by American guidelines. All the American guidelines also are stating this fact, as well as it is given by the WHO labor care guide also. Unless there is some fetal compromise or any other associated complication, just for prolongation of latent phase, cesarean section is too drastic an intervention. It should not be done. On the other hand, the management is supportive care and oxytocin or amniotomy or combination of these two. So that is how we need to manage prolongation of latent phase rather than directly taking a decision for cesarean section. Now, this how we define active labor. What is the demarcating point, or what is the landmark in the cervical dilatation beyond which we say that labor has entered into active labor? There is so much of difference in the various guidelines in the at present. Presently, there is so much of controversy mainly related to how we define active labor. When do you say that patient has entered into the active labor and latent phase has been passed by the patient? So for that, all the American guidelines, ACOG 2019, SMFM is a organization of high risk obstetricians catering to the high risk pregnancies. ALSO is the advanced life support obstetrics, which is run by American Association of Family Physicians. So practically all these are American guidelines which do follow the ACOG guideline as the primary, and ACOG has given that we should demarcate the difference between the latent phase and active phase at 6 centimeters. That means whenever dilatation of the cervix is greater than or equal to 6 centimeters, labor has entered into the active first stage of labor. That is a definition given by American guidelines. On the other hand, WHO Labor Care Guide 2018 is a landmark recommendation which we all obstetricians have for managing labor. It has also been endorsed by FOXI, that is Federation of Obstetric and Gynec Society of India. It has also given labor care guide as the guiding guideline for us obstetricians in India to follow. What WHO labor care guide defines active labor is whenever the cervical dilatation is greater than or equal to 5 centimeters. On the other hand, United Kingdom and mainly the NICE guideline, that is the Government of United Kingdom guideline 2023, is still continuing with the definition of active labor as greater than or equal to 4 centimeters, and terminology used by this UK guideline is not active labor but established first stage. It says that whenever the cervical dilatation less than 4 centimeters or up to 4 centimeters as latent first stage, and whenever it is equal to or beyond 4 centimeters, the terminology which is used by UK guideline is, NICE guideline is established first stage, but it is equivalent to active labor. So we can see that 4 centimeter, 5 centimeters, 6 centimeters, there is so much of difference in the definition of active labor by various societies and various guidelines. NICE guideline 2023 is by UK government. It differs from American guideline WHO labor care guide. Terminology, as I said, is uses latent first phase up to 4 centimeters with uterine contractions. Established first stage whenever dilatation is greater than 4 centimeter and there is a progressive dilatation of cervix with regular uterine contractions. Friedman curve, which is used traditionally which was used traditionally all over the world before we have this change in the active phase definition after 2014, around 2014 was 4 centimeter traditionally as start of active phase of labor. So this UK NICE guideline coincides with the traditional definition of onset of active phase as greater than or equal to 4 centimeters. On the other hand, all the American guidelines are giving the definition of active labor as dilatation greater than 6 centimeters and no cesarean section only for delay in labor should be done up to 6 centimeters. That means latent phase is up to 6 centimeters and prolongation of latent phase is an indication for interventions such as ARA, rupture of membranes and oxytocin administration, and not an indication for cesarean section as a per se indication. That students need to remember that now there is a change in thought. Whenever we are writing indication of cesarean section to 6 centimeters, only non-progress of labor, delay in labor should not be the indication for cesarean section. ACOG is American Professional Membership Organization for Obstetrician Gynecologists. It has given in 2014 itself this change in the active labor definition as cervical dilatation greater than 6 centimeters. SMFM is Society for Maternal Fetal Medicine, which is mainly the American Society of High Risk Pregnancy Experts. It is also following this 6 centimeters as the demarcation. ALSO is Advanced Life Support in Obstetrics, which is sponsored by American Association of Family Physicians, and it is as latest as 2023. It is also giving us the definition of active labor as greater than or equal to 6 centimeters. WHO Labor Care Guide was formulated in 2018 and it was available to all of us from 2020 onwards, and it has also been endorsed by Indian guideline, that is FOXI guideline. What WHO Labor Care Guide says is initiate documenting in the Labor Care Guide. It has given like a partogram. It has given this as a Labor Care Guide, and every obstetrician should start uh, documenting in this on this paper or initiate the labor care guide in active phase of 4 stage of labor. And active phase of labor is whenever there is a cervical dilatation of greater than or equal to 5 centimeters. These are the 7 sections which are there in the labor care guide, and all the students should know by heart. That first is basic information, then second is supportive care, baby care, maternal care. Fifth is labor progress. Sixth is medication given, and seventh is the shared decision making. So for this fifth labor progress, mainly you start entering into the this labor care guide whenever the cervical dilatation is greater than or equal to 5 centimeters. Now, why this active phase demarcation has changed from 4 centimeters to 5 to 6 centimeters? What was the main reason? Now, this is the most important slide, I should say, for all the students, and you also practice drawing this line diagram, because it is the main concept which has resulted in a profound change in how we look at normal labor, how we manage labor, because the most common job of obstetricians is to manage normal labor. And this is a major change in that we consider active phase, whether we consider it at 4 centimeters, 5 centimeters, or 6 centimeters. So this is yellow line is the Friedman curve. Friedman introduced it in way back in 1955, where acceleration of the curve starts at 4 centimeters itself. You can see this is on y-axis, we have cervical dilatation, and this is the 4 centimeter dilatation, and the graph shows phase of this is stage of acceleration 3 to 4 centimeter, then stage of maximum slope, and then deceleration from 9 to 10 centimeters. That is how active phase was divided by Friedman. And this especially 4 to 6 centimeters have a steep curve. It has a steep curve. You can see that, appreciate that. Zhang in 2002, he developed this another curve which is called as Zhang curve, based on the multiple the studies which he conducted over 4-5 years on multiple patients who delivered normally with a good obstetric outcome, where what he suggested was there is an acceleration which takes place not at 4 centimeters but at 6 centimeters. 4 to 6 centimeters, the curve is not steep like it is shown in Friedman. It is comparatively a flat curve. As compared to Friedman, it is a flat curve from 4 to 6, and that is how the idea or the concept came that we should be calling the active phase not from 4 centimeters but from 6 centimeters, because from 4 to 6 also the labor curve is not accelerating much. It is almost as a line which is going along the same direction, and then suddenly there is a change after 6 centimeters and the patient delivers. So up to 10 hours, according to Zhang curve, there is a gradual change in dilatation from 4 to 6 centimeters. It is not within an hour or less than that. It takes more than 2-3 hours for from 4 to 6 centimeters is the main difference between Friedman and this Zhang curve. I request all the students to practice this diagram, so that in examination, if you get this theory question on dystocia, you should be able to draw this. As well as concept wise also, it helps us to understand why there is a change from 4 centimeter to 5 to 6 centimeters to define active phase of labor. So by this Zhang curve, up to 6 centimeters, it is latent phase. After 6 centimeters only, there is an active first stage of labor. Till now, what we have seen is mainly the how we define dystocia and what are the controversies related to the definition of active phase itself. Now coming to the diagnosis of dystocia. By American guidelines, it has been divided as protraction and arrest disorder. Protraction is slow dilatation of cervix, which is taking place after 6 centimeters, that means in active phase, where the rate of dilatation is 0.3 to 0.4 centimeters per hour or even less than that. In other words, if we repeat per-vaginal examination after 4 hours, the dilatation will be less than 2 centimeters. Arrest disorder is defined whenever the dilatation of the cervix is greater than 6 centimeters and bag of membranes is ruptured, or there is an artificial rupture of membranes has been done. With that, there is no dilatation, no change in dilatation for greater than or equal to 4 hours with good contractions, or greater than or equal to 6 hours with inadequate uterine contractions. Now, for students, I want you to remember these uh, figures, and that is why I have made these in yellow as well as in bold, that for slow dilatation or protracted dystocia, what figure you should remember is 0.3 to 0.4 centimeter per hour or less than that. Whereas for this arrest, you need to remember that no dilatation for greater than or equal to 4 hours with good contractions, or 6 hours with inadequate contractions. So this is important slide, and the diagnosis of dystocia is based on these figures. When to consider delay or dystocia as per WHO Labor Care Guide 2018. Now, as we can see in this table, for each centimeter of dilatation, Labor Care Guide has given a different duration as an alert. Now, alert given in the Labor Care Guide is indicates that you need to take some action. But if it is not an alert, that means labor is progressing normally. So as we can see here, 5, 6, 7, 8 and 9 centimeter for each centimeter of cervical dilatation. How many hours we should wait before taking action is this alert. So if the 5 centimeter dilatation, excuse me, if 5 centimeter dilatation remains same for greater than or equal to 6 hours, then we are supposed to consider that there is dystocia and take the appropriate action. Same for 6 centimeters, 5 hours, 7 centimeters, 3 hours, 8 centimeters, 2.5 hours, and 9 centimeters, 2 hours. So for postgraduates, it is mandatory that you need to learn this table by heart, as you can get a long answer question LAQ on this WHO Labor Care Guide 2080, because it has got a profound impact on management of normal labor all over the world. So like that, how you remember is for 5 centimeters, it starts from 6. So remember that initial number is 6. For 5, it is 6, and then you remember 6, 5, 3, 6. Somehow you will have to make it by heart that it is 6, 5, 3, 2.5, and 2 hours. So for 9 centimeters, you wait for 2 hours. For 5 centimeters, you will wait for 6. In between, you remember 6, 5, 3, 2.5, and 2. And this is if it is in your labor room, as a display in your labor room, and if you see on daily basis, then it will be very difficult for you to even memorize this graph. Now coming to the second stage dystocia, it is usually the maximum change which happens in second stage of labor is a descent. And whenever it fails to take place, then we say that dystocia in second stage is arrest of descent is there. Now for that also there are two schools of thought. Traditionally, we used to consider the duration of second stage normal for nulliparous 2 hours and multiparous patient as 1 hour. If epidural anesthesia, analgesia is being used, then 1 hour was added. But for nulliparous, you wait for 2 hours after the full dilatation for patient to deliver, or you start considering it as a prolonged second stage, and multiparous, you wait for 1 hour. But ACOG 2019 as well as WHO Labor Care Guide 2018 are giving us different recommendations. Nulliparous, at least 3 hours of pushing, that is active second stage. They are dividing second stage in passive and active. Passive is when there is full dilatation but there are no bearing down efforts. Active is when patient is having voluntary, involuntary contractions of abdominal muscles with bearing down efforts or pushing. So when she is pushing and she is pushing for at least 3 hours in a nulliparous patient, then only you consider that there is a prolonged second stage, and multiparous 2 hours of pushing. Now this recommendation is also having controversies. It is also controversial, as some studies have shown that it leads to serious neonatal morbidity. There are concerns about the neonatal outcome, and that is why it is given in textbook also that these recommendations require further research. Till now we have seen the what is labor dystocia and how we define it, and what are the types of labor dystocia and how we diagnose labor dystocia as per various guidelines, and how now coming to the management of labor dystocia. Hydration is the mainstay and easy intervention, and quite effective also, where if patient is not taking oral fluids adequately, then you give with labor for prevention of labor dystocia as well as treatment, we have to give 250 ml per hour of IV fluid, which is quite effective. Second intervention is DOLA support or labor companion support, which prevents dystocia. It has been proven that if there is a DOLA or there is a companion with the patient which has been selected by her in the antepartum period itself, that companion might be a friend or a close relative who who has been trained in antenatal period only on how to provide the support, and that companion is mainly taking care of one P, that is psyche, and that has a profound impact by reducing the duration of labor, preventing dystocia, and reducing number of cesarean sections also. And I hope that all over the world we all start making our labor rooms companion friendly or dollar friendly because of this scientifically proven advantage. If we do either amniotomy or give oxytocin alone, both are not very effective, but whenever these are used in combination, amniotomy and oxytocin is more effective, and it is more effective for prevention of dystocia as compared to for treatment of dystocia. But still, though the efficacy is doubtful for treatment of dystocia, this amniotomy with oxytocin forms the mainstay in the management of dystocia. Now, Old Driscoll was the first person who introduced the concept of active management of labor long back in 1980s, and he introduced the concept of using amniotomy and oxytocin as a routine to reduce the duration of labor, to reduce dystocia, and to reduce cesarean section rate, which is being done for dystocia, and there was a successful this protocol of active management of labor with the um, good obstetric outcome, maternal as well as neonatal. So the credit goes to the old Driscoll for using this amniotomy with oxytocin to prevent dystocia. Now this flow chart shows us the how the this first stage delay or dystocia is managed as per NICE guideline, UK guideline 2023. Here the protocol starts at 4 centimeters because active management is considered as dilatation greater than or equal to 4 centimeters. Vaginal examination is recommended on 4-hourly basis. Anytime dilatation is less than 2 centimeters, PV examination is again repeated after 2 hours. If it is greater than or equal to 1 centimeter, patient enters into the continued care or routine care. But if it is less than 1 centimeter, then artificial rupture of membranes is recommended. After ARM, again we have to wait for 2 hours to see whether the progress is there or dilatation is there. If cervical dilatation is greater than or equal to 1 centimeter, patient enters into continued care. If there is no progress at this stage, an obstetrician has to evaluate the patient mainly along the 6 P's we have seen as power, passenger, passage, patient, psyche, and provider. and mainly to evaluate and see the cause of dystocia and to again reassess and confirm the diagnosis of this dystocia. And if everything else is ruled out, then at this stage oxytocin administration is recommended, and now at present the recommendation is of high dose oxytocin. After 4 hours of good uterine contractions with oxytocin, if there is no progress, it is an indication for cesarean section, with the indication as dystocia not responding to oxytocin and ARM. But if after 4 hours of good contractions, the dilatation is greater than or equal to 2 centimeters, the labor continued with the continued care as in normal labor. So this is in short. Here also we can see that around 8 hours we are giving a trial for the patient to progress in labor after detecting this protraction for the first time. ACOG 2019, it introduced, or it had, there was a committee which was formed mainly for, and that committee gave the recommendations which are called obstetric consensus committee recommendations, and postgraduate students should know this because these have impacted the way we look at labor all over the world in a great manner. And these recommendations are mainly concerned about when to do cesarean section in dystocia. It says that no cesarean section for prolonged latent phase. Prolonged latent phase is an indication for either supervised observation or for amniotomy with oxytocin, but for cesarean section. Protracted active phase dilatation also same management, but no cesarean section. Active labor is to be considered with cervical dilatation of greater than or equal to 6 centimeters is the most important and most controversial recommendation of this obstetric consensus committee. Caesarean section is done for arrested active phase. If the definition of arrest we have already seen and I am repeating it, if there is no dilatation for greater than or 4 hours with good uterine contractions, or for greater than or equal to 6 hours with inadequate uterine contractions, then it is labeled as arrest, and we can do the caesarean section. Now, whenever we are using oxytocin in labor, my request to all the postgraduates is you must express oxytocin as in milliunits per minute. If I am asking you how you start oxytocin drip and how much you give, you should never say that I start with 2 units and then I increase it by one unit. That is, there is a catch in that you are not considering the drip rate. That means you are not aware of change in the dose with the drip rate, and that is why my request to the all the consultants and postgraduates is you understand this slide and always express the oxytocin administration, how much you are giving in milliunits per minute. Now, if we are giving 1 unit oxytocin, if it is added to 500 ml of ringer lactate, then depending on drip rate, we know how much patient is being receiving. If the drip rate is 20 drops per minute, patient is receiving 1 ml per minute with the usual IV drip. And if it is a micro drip, patient is receiving 60 micro drops per minute, that is equivalent to 1 ml per minute. 1 unit is equivalent to 1000 milli units, and if we are adding 1 unit to 500 ml, we are adding 1000 milliunits to 500 ml, which means that 1 ml contains 2 milliunits. So if we are giving 1 unit in 500 ml at 20 drops per minute, patient is receiving 2 milliunits per minute. I hope you have understood till now. So now as we keep on increasing the concentration, instead of 1 unit, if you add 2 units, it will be 4 milliunits per minute. If you increase the drip rate, double the drip rate to 40 drops per minute, those will increase to 8 milliunits per minute. You are increasing the concentration further increase will be there. So like that, it depends on two things. How much is the concentration and how much is the drip rate. That decide how many milliunits per minute a patient is getting. Now this is a chart which I want all the consultants and postgraduate students to have in your labor rooms. so that whenever the patient is being given oxytocin either for induction of labor, augmentation of labor, or as active management of labor to prevent dystocia, anytime we are giving oxytocin, intrapartum use of oxytocin, then this chart will be of great help. Here, if whenever we are giving, again the same thing, 1 unit 20 drops per minute is 2. Now, why I have circled this 4, 2, 4 is here we can see that when drip rate is increased, the dose increases. Similarly, if you increase the concentration, then also the dose increases. And the dictum is, it is better to increase the concentration than drip rate. And it is mainly true whenever we have a case of either anemia or preeclampsia. These are the patients where if you keep on increasing the drip rate from 20 to 40 and from 40 to 80, what will happen is patient will end up in pulmonary edema. So you want to prevent pulmonary edema, what we should be doing is, instead of increasing the drip rate to increase the dose, we should be increasing the concentration of oxytocin. We should be adding more units here. Again, 1 ml equal to 20 macrodrops per minute or 60 microdrops per minute. Now, this 36 is the maximum dose which is given by American guidelines. Though there are some studies which show that higher dose can be used without any perinatal morbidity or mortality, but this is usually considered as standard maximum dose where we are adding 9 units, giving at 40 drops per minute. That patient will be receiving 36 milliunits per minute. Now, for oxytocin administration also, presently if we see the literature and textbooks, there are two regimes which are given. One is low dose regime, other is a high dose regime, and current guidelines are all recommending this high dose regime at present. Low dose is, your starting dose is 1 milliunit per minute. Example is, you take 1 unit, add to 500 ml and give with half ml per minute as 10 macrodrops or 30 microdrops per minute. Then you increase by 1 to 2 milliunits per minute every 15 to 40 minutes. In high dose, starting dose is 6 milliunits per minute. How you ensure that your patient is receiving 6 milliunits per minute is 3 units is added to 500 ml with a patient receiving 1 ml per minute. That means drip rate is either 20 macrodrops or 60 microdrops per minute. You increase this if there is no adequate response or contractions are still inadequate. You increase by 6 milliunits per minute every 15 to 40 minutes. Now, whether to increase every 15 minutes, every 30 minutes, or every 40 minutes, that depends on our own institutional protocol. But the main difference will be, shorter the interval, more is the success rate of oxytocin administration, but it is associated with greater risk of tachysystole. So that we need to remember, and accordingly we need to decide whether to increase it more frequently every 15 minutes or a little later after 30 or 40 minutes. Now this I have slide I have deliberately included from Williams Obstetrics as Parkland Hospital Protocol to Diagnose and Treat Dystocia, because I want all of us to have similar our own institutional protocols to manage labor. Now, what is their protocol is, they are admitting the patients whenever patient is in active labor or with confirmed rupture of membranes. They are not admitting patients in latent phase. Active labor is defined as dilatation of greater than or equal to 4 centimeter with regular uterine contractions. With 4 cent after that, after hospitalization, pervaginal examination is done every 2 hourly. Anytime dilatation is 1 to 2 centimeter per hour, then it is considered as normal with good uterine contractions whenever the dilatation is 1 to 2 centimeter per hour. If there is no change in dilatation in 2 hours, then artificial rupture of membranes is recommended. No change in dilatation after 2 hours of ARM is an indication to start high dose oxytocin drip. And with high dose oxytocin drip, if the dilatation remains same even after 4 hours, It is an indication to do cesarean section with a indication written as dystocia not responding to artificial rupture of membranes with oxytocin. So we can see here total 8 hours are given to overcome slow cervical dilatation of less than 1 centimeter per hour by this protocol also. Even like that means whenever you have a dilatation which is less than say expected 1 to 2 centimeter per hour, you don't do cesarean section at this stage. After that, you do ARM, wait for 2 hours, start oxytocin, wait for another 4 hours, and then only you go for cesarean section provided everything else is normal. Complications of dystocia. We are discussing so much about labor dystocia. So what are the complications if we don't diagnose it early and don't treat it or manage it correctly? Is intrapartum chorioamnionitis. Intrapartum chorioamnionitis is a risk factor even for fetal morbidity or mortality also. Postpartum endometritis or sepsis is a life-threatening complication which can occur. Atonic PPH is another life-threatening complication which can occur in any patient with prolonged first stage or second stage of labor. Uterine tears are seen occurring more frequently during cesarean section whenever it is done for second stage dystocia, because here the lower uterine segment is excessively stretched and thinned out. So you must have experienced that second stage cesarean section always there is a risk of whenever you give a incision and deliver out the baby, extension of incisions, tears in the angles of the uterus or even in the middle part of the incision, and that leads sometimes to excessive bleeding and intraoperative hemorrhage can occur. Uterine rupture and fistulas are the complications seen with neglected cases of dystocia where there is a complete mismanagement. These are also this uterine rupture is life threatening and fistula leads to serious morbidity. So with in fistula such as vesico-vaginal fistula, vesico-cervical, or even recto-vaginal fistula can occur because of the impacted head compressing the tissue between the hard head and the pelvis, and then it gets sloughed off after many days, leading to this any of these fistulas. Neonatal complications are also common with neglected cases of dystocia, such as neonatal sepsis, sometimes leading to mortality also perinatal. Trauma can occur, cephalomatomas and skull fractures are also uh, documented with the neglected cases or mismanaged cases of dystocia. Take-home message is dystocia is a controversial topic. Guidelines differ drastically. We need to have our own institutional guidelines. A small change in labor management has a potential to impact adversely two lives, mother and baby, such as, for example, whether you consider active labor at 4 centimeters, 5 centimeters, or 6 centimeters. It can have a profound impact on the obstetric outcome with a change in the maternal as well as neonatal outcome. We should always know our dose of oxytocin and it should always be expressed in milliunits per minute, and for that also we should have our own hospital protocol. We need to choose the guideline judiciously because each guideline is for their own population depending on their local evidence. Similarly, for our population, we should have our own guideline depending on whether we have more patients who are short-statured or more patients who are elderly, obese. All these risk factors or having abnormal types of pelvis such as android pelvis. Depending on that, we need to have our own and how many intrauterine growth restricted patients we have, or how is our perinatal care, how is the neonatal care facility, how is our overall infrastructure. All these factors will decide about which protocol we should follow, and accordingly we have to select the protocol. Once we select the protocol and form our institutional guideline, it helps us in uniform application of the guideline to all patients, as well as it helps us medico-legally. Thank you so much. These are the references from Williams textbook of obstetrics, WHO labor care guide. All students, I request all of you as well as consultants to go through it, as there are so many positive recommendations which we can apply in our day-to-day practice. Now, management of normal labor is a part and parcel of obstetricians' daily life. And wherever there is even a small recommendation which is useful, it really helps many women. Nice guideline on management of normal labor 2023 and ALSO 2023. Thank you once again.